So we're going to talk a little bit about what's new in diabetes. And I have no disclosures for this. Unfortunately, we are exceeding our expectations in the epidemic of diabetes. And particularly if we look at India and Southeast Asia, it was predicted that we were going to have a lot more diabetes in these areas by 2030, and the predictions are being exceeded. We've almost reached the 2030 predictions, and we are only in 2015. So we're way ahead of schedule in getting mostly type 2 diabetes. So we'll look today at what we can do to prevent it. What we need to do here is we need to identify the high-risk population that's coming to your office. Take a look at these folks, and they are going to be the folks you were telling me about in the beginning. They're going to be the obese people with metabolic syndrome. I don't know if is this as loud as it usually is? Okay. Well, they're going to be the obese people with metabolic syndrome. They're going to be the PCOS people. I mean, those are the people you're going to be seeing in your office, and those people have one foot on diabetes and the other foot on a greasy McDonald's French fry. So we can actually help prevent diabetes in these people. People with high triglycerides and low HDL. So again, we can prevent more than 50% of diabetes if we just counsel people about lifestyle, if we screen annually, if we nag at them. And I told you about the Finnish prevention study, and all they did was to go to people's houses and make sure that they ate the proper diet. They made sure you got to the gym, and if you didn't go to the gym, they went and picked you up. So, you know, all they did was nag at these people to have a decent lifestyle, and when they did, 58% fewer of them developed diabetes. So, again, how about ethnicity? And we know that ethnicity is extremely important. We know that Asians develop diabetes very rapidly after the BMI exceeds 24. We talked about that before. They're the most high-risk population. And so this year, the ADA says if you have Asians in your practice, you need to begin screening them when the BMI is 23. And you say, excuse me, that's not even really overweight. It isn't. But they develop diabetes sooner, so you need to screen them more aggressively earlier. The others of us are much less susceptible to developing diabetes. We can screen them a bit later, but you need to get going on the Asians. Okay, how to screen, again, not changed this year. They suggest the A1C is a very credible way to screen. And remember, 5.7 to 6.4 according to the ADA, 5.5 to 6.4 according to AACE, high risk for diabetes. About a third of those people will develop diabetes every year for the next 3 years, and by about 3 years, the vast majority of them will have diabetes. Diabetes diagnosis, A1C 6.5 in a venous sample obtained at the laboratory, not a point of care. Now, why the A1C? Well, it's more convenient. You don't have to be fasting. It's more static. People keep the A1C for longer, and it's much less variable than your fasting sugar or your 2-hour post-meal sugar. Those are fairly variable. It's not useful in states of abnormal red cell turnover, transfusions, and you don't want to use it in people with cystic fibrosis. They have a rapid turnover rate of their hemoglobin, recent blood loss, again, anemias. But it's okay to use at the first prenatal visit. So if you see someone who's pregnant, you can grab an A1C. What are you identifying there? Not the people who are going to get gestational diabetes. They're further along. We hope your first prenatal visit isn't at 24 weeks. So what we're doing is to find the people who already have diabetes who have become pregnant. And those are the people who have the highest risk for birth defects, the highest risk for problems with their pregnancy, because they don't know they have diabetes. And as they get into the second trimester and have more insulin resistance, they can become extremely ill. They can develop very high blood sugar. So you want to find them early. You may miss a few people. About a third of the people have a glucose that's really 126 fasting before they have a glucose that's high in the postprandial state. The vast majority of people with diabetes have postprandial hyperglycemia first. The muscle is the most resistant organ to insulin. And then fasting hyperglycemia second when the liver resistance comes into play. Okay, so what do they say about this? What are we going to do about it? Well, caloric restriction is the key, And if we're looking, you can have any kind of a diet you want. You can have a low-carb diet with 6 to 8 starches, monounsaturated fat, helps to decrease insulin resistance. Nuts is there, because this year there was an interesting study in Nutrition, Journal of Nutrition, showing that people who ate more high-fiber nuts had fewer diabetes, had fewer lower incidence of diabetes. Oh, what can I say? But the Mediterranean diet has been shown overwhelmingly in several studies to decrease the risk of diabetes. So, you want your patient says, what can I do? I'm in a cloud here. The ADA is saying that any caloric restriction is fine as long as it doesn't matter what diet I use. We talked yesterday about obesity. Didn't matter what diet I used as long as I used fewer calories. I want a diet. I want you to give me a sheet. I tell them it's not a diet, it's a food plan for life. Go online, get the Mediterranean diet. It works. And of course, fresh fruits and vegetables are important because they have fiber, they decrease constipation, and they decrease insulin resistance. So there are the few clues about diet. We'll talk a little more about that on Thursday. And exercise, they haven't changed their mind. 150 minutes of exercise a week is an effective preventative of type 2 diabetes. When to use metformin? Yes, in practically everybody. You see this laundry list. Anybody who has a glucose intolerance, anybody who has an impaired fasting glucose, and anybody who has a BMI of greater than 35, age 60 years, virtually anybody. And the whole key is if you try lifestyle, and if you try it for 3 months, and the patient comes back to your office, they're still snacking on Hostess Ho-Hos, and they haven't gotten nuts into their diet, just say, heck with it. You know, please improve your diet a bit and start metformin, because metformin does work. Not quite as well as lifestyle, but you know, many of us are not totally committed to lifestyle changes. It's hard when you're older, and so get on with it and get them on metformin. I see too many people waiting too long to get their patients on metformin to prevent diabetes. The other thing they're asking us to do is to be sure we look at women with prior gestational diabetes, because they're going to get type 2 diabetes down the line. Remember, gestational diabetes is just that I added the pregnancy insulin resistance to your personal insulin resistance, and it overwhelmed your pancreas. And so as you get older and you add more pounds or you add more years to your personal insulin resistance, you're going to get diabetes. These are high-risk patients, and we have evidence that putting them on metformin will decrease the onset of their diabetes. And so the other thing they tell us is we must control the cardiovascular risk factors. Back to the statin in those people, back to watching their blood pressure. Those are very important, because if we don't control those, we'll diagnose their diabetes when they already have coronary artery disease. Don't want to do that. How about the treatment guidelines this year? Not much change from last year. Our goal is less than 7 without hypoglycemia. Very important, particularly in your older patients who have comorbidities. Blood pressure hasn't changed. In type 2, less than 140 over less than 90. In type 1, less than 130 over less than 80. Because remember, hypertension in the type 1 diabetic is renal disease until proven otherwise. It is just they don't get hypertension as part of their disease. Type 2 people get hypertension as part of their disease. Usually they have it before they even get the diabetes. And we just talked about the fact that the ADA says that we no longer have an LDL goal this year. We're not using the risk calculator for patients with diabetes, although frequently it comes out to the same place. We're just counting LDL as one of the risk factors. And triglycerides, they have said this year again that lifestyle is the treatment of choice for hypertriglyceridemia until the triglycerides get to 1,000 or more. And then they said you may use fish oil, you may use omega-3 fatty acids, that is. You may use niacin, you may use a fibric acid derivative. They suggest that you don't use gemfibrozil. They suggest that you use fenofibrate. But they say all of those have equivalent evidence that they will work for you. If you use niacin, you have to be careful. You don't want the glucose to rise. How about our approach to hyperglycemia? They say you must individualize the A1C for each of your patients. We don't just want to say across the board, Mrs. Jones should be less than 70 and she has unstable angina, and Mr. Smith should be less than 7 and he has nothing. He has no complications. We want to look at the patient's complications. We want to look at the risk they have when we give them hypoglycemia. Because remember, if you have your patient with a hemoglobin A1C of less than 7, unless they're diet controlled or controlled on metformin, you have a significant risk of hypoglycemia in these patients with almost all the medications we're going to talk about and that you're going to use. So we definitely want to look at hypoglycemic unawareness. As people develop autonomic neuropathy with their diabetes, they also don't know when their blood glucose is getting low. And I have patients who have seizures when their glucose is 40, and up to that point, they didn't even know it was low. They don't have the symptoms that most of them have. They don't have the sweating. They don't have the discomfort. They don't have the tachycardia. They only have the neuroglycopenic symptoms. They don't feel right, and then they have a seizure. So we have to watch very carefully those people with autonomic neuropathy. We have to watch very carefully the people who have cardiovascular comorbidities. And in them, a slightly elevated glucose is much better than a slightly low glucose, because the low glucose, as we found out in the ACCORD study, can be deadly for those people. How about the diet? We said, well, the ADAs, there's just no ideal macronutrient distribution. You can have a high protein diet if you don't have renal disease. You can have a high carb diet, as long as they're complex carbs, and so on and so forth. But they do have a couple of principles. Portion control. We shouldn't eat everything. And if we look at this lady, you can see she's all dressed to eat her pepperoni and mushroom pizza in her pepperoni and mushroom dress. And she needs to know that 2 slices of that pizza are it. Uh-oh, none of us can eat 1 chip or 2 slices of pizza. So I tell my patients probably best to avoid it or get a personal small one. The other thing is that they need to avoid concentrated sweets. We don't have anything except perhaps inhaled insulin that's going to take care of your hostess ho-ho. I am sorry. Okay. How about bariatric surgery? Once again this year, the ADA favors bariatric surgery, and they say type 2 diabetes, BMI of 35, but now they've inched down, and there are a number of places that are doing it at even lower, at about a BMI of 30. If your patient has totally uncontrolled diabetes and you can't do anything else with them. Poor control with lifestyle and pharmacologic therapy. Okay, so who doesn't have that in some of their patients? Particularly as you get patients in the 300 to 400 pound range. You're going to have a very difficult time controlling them. They have a lot of insulin resistance. You're going to be using a lot of insulin. And I'll show you cases we go on where you used a lot of insulin and then a lot more insulin and nothing happened. When you get to that point where you say, all right, I've got you on 200 units of insulin a day, and your A1C is 8.5 or 8.6, that's when you're going to think, I've got to stop here. I have got to get this person into bariatric surgery because I'm not going to do it with the meds I have at hand. Well, if you thought there was a profusion of diets, you should see the profusion of meters, delivery devices, and tablets in type 2 diabetes particularly, but once again here, this year in type 1. So let's take a look at our realistic goals. We're going to have a goal for each patient. Obviously, we want to control the glucose, but we also want to avoid hypoglycemia, and that may be our most important goal in many of our patients with type 2 diabetes, is don't ever let them have a low blood sugar. The 83-year-old lady who's been in the ER 4 times for hypoglycemia doesn't need to have a hemoglobin A1C of less than 7. We definitely in our type 2s want to avoid weight gain. And even our type 1 patients, if they eat too much, take too much insulin, they're going to get chubby, they get insulin resistance, it's more of a problem. Metformin is always suggested by everyone initially unless the patient has a contraindication. And if their A1C is greater than 7.5, the chances are very great that you're going to need at least 2 agents. It's like hypertension. As you go up the scale and you get worse, you're going to need more than one medicine. You're going to need more than one mechanism of action. The A1C is greater than 9, you ought to think about using insulin. And the big thing is you need to change this. I see people coming to my office who are just, they've been on the same 4 oral agents for 5 years, and it's time for insulin, and it's been time for about 4.5 years. And it's not the fault of the provider necessarily. It's sort of a shared stagnant situation. They say, I can't afford it. You say you really need to do it, and so on and so forth. So just bite the bullet and get on with it. Metformin is the first choice, and everybody says, well, why is that so? Well, this is a huge study. There's 15,000 patients, and about 9,000 of them were started on metformin, and the others were started on something else as a first-line drug. So they were started first on metformin or many other things. They looked through the database, and they found that starting with any of the other meds didn't fare as well. They had to have a second oral agent sooner. They had more problems. They had TZDs. They had swelling in their feet. They had sulfonylureas. They got hypoglycemic. And the DPP-4 inhibitors in general didn't work. So again, metformin is first. There are fewer adverse effects. It works better. Just try it out. Remember, you can use it until your patient has stage 3B disease. Actually, you can use it down to stage 4 if you look at the renal guidelines. The ADA is a little conservative, but the Kidney Association says that if your estimated GFR is 30 or greater, you can use metformin. Just cut the dose in half. Your maximum dose is 1,000 instead of 2,000. As you get up to an estimated GFR of 45, then you can use 2,000. You have to watch those people who are in the 30s, because if they get dehydrated, the metformin level may rise. But lactic acidosis is very uncommon, and metformin is a very excellent pharmaceutical. How about the classic anti-diabetic agents? You know all these. You know the sulfonylureas. They decrease A1C by 1 to 2%. They're excellent. You know about the TZDs. If you use a TZD and you're adding it on and you're going to add insulin, you've got to be very careful, because insulin causes fluid retention. So does the TZD. Thiazolidine diones also increase the risk of fractures, as we saw yesterday. So a little iffy on those. Be careful of them. But they do decrease A1C, again, by about 1 to 2%. The sulfonylureas and TZDs reduce post-meal insulin, and metformin reduces mainly the fasting glucose. Okay, one of the biggest new things in our armamentarium we've had for several years are the GLP-1 receptor agonists. But I mentioned the classic compounds because if you look at the average insurance company, they will not allow you to use a GLP-1 receptor agonist unless the patient has tried metformin. That's one set of insurance companies. And another says metformin plus another classical anti-diabetes agent. So you need to remember that. Start them with metformin. When that doesn't work, you're probably going to have to add another agent, probably a sulfonylurea, before the insurance company is going to pay for that GLP-1 receptor agonist. So save yourself a lot of paperwork, get them on the metformin, put them on a low dose of sulfonylurea, and then move forward. And when those don't work, and frequently they don't, then you can fill out the form and get them a very effective medication that will work. Receptor agonists work very nicely. They lower A1C by about 1.5%. And as you can see, there are an extensive number of them. Nothing new about any of them. They can result in significant weight loss, as we saw yesterday, but frequently they do not. So I would not count on them for weight loss. I would certainly count on them for weight neutrality. So your patient can do well with them. They don't cause weight gain. They shouldn't be used in gastroparesis because they result in significant nausea and vomiting. And stage 4 renal disease, you have to be very careful of these. They can cause very significant hypoglycemia in stage 4 renal disease. Okay, so let's take a look at some cases. We're going to look at our approach to the uncontrolled diabetic. The first thing we're going to do is to make sure that we know our A1C goal. That's where we're going. And we still have goals in diabetes, and so we want to know what the A1C goal is for your patient. Then we want to know where the problem is. And I see probably about 40 people with uncontrolled type 2 diabetes a week, and frequently the problem that they're having is that no one looked at where the problem was with their glucose. And so we need to know, where is the problem? Is it post-meal? Is it fasting? Is it just plain everywhere? We need to look at medications that are targeted toward the problem. So you can help with these. There are a bunch of answers. This is a 56-year-old male with type 2 diabetes. He's had it for 9 years, and his A1C is 8.9. Takes metformin, 1,000 milligrams BID. 9 years, statistically, he probably has coronary artery disease. Fasting glucose looks pretty good, right? You know, 85 to 180. In my office, that's halfway decently good when you come in the door. So a BMI of 36. So what's his A1C goal? What do you want for him to have? Back in your mind, remember, he probably has some coronary artery disease because he had this disease a long time. It's been uncontrolled. Uncontrolled for more than 5 years. You've got crud in your coronary arteries. So A1C goal? Less than 7? Probably not. Less than 7.5. You know, Kaiser Permanente did a study, and they just looked at A1Cs and expected death. They just took 2 points in time. They took your A1C when they first met you, and then they looked at when they died. And they have a huge database. They could do that. And the people with A1Cs of 7.5 lived the longest. People with A1Cs of less than 7 were okay. People with A1Cs of more than 8, oh, they lived the shortest. So that gives us kind of a clue as to where we're heading. So this guy may have coronary artery disease. I'll pick 7.5. You're too quiet. Okay. His PM glucose. We're going to look, where is the problem? Well, he has to check his glucose. I mean, how many of your patients bring the glucose log along with them, their meter for their download? Oh, like my patients, right. I give you 3 chances for that, by the way. I have a busy practice. If you don't bring your meter the first time or some sort of blood sugars, I tell you about that, and I say, you know, we ought to do this the next time. You come the next time, the dog ate your meter or whatever, that's 2. I say, look, Mrs. Schmedlap, we need some glucose data here, or I can't do anything. I do stuff, but, you know, I tell them this. I can't do anything really effective for you, so if you don't bring it next time, you don't come again. You'd be amazed the number of people that bring it the 3rd time. Okay. So, does that sound harsh? No. No, thank you very much. Okay. Yes. So, at any rate, this gentleman's food plan is reasonable. I'm sorry he's a man. I could put an FE in front. And so, he checks his glucose twice a day. He brings them along. Does he have complications? That's our next question, because that's going to limit us. So what are we going to use? We can use a TZD. We can use a sulfonylurea. We can use a GLP-1 receptor agonist. I think I'd use a GLP-1 receptor agonist. That's the newer thought on this, because what do we want to do here? Do we want him to lose weight, gain weight, stay the same? We want him to lose weight. And we at least want him to stay weight neutral. I mean, this guy has a BMI of 36. And so, yes, we're going to try for the GLP-1 receptor agonist. How about case 2? He's very similar. 56-year-old male with type 2 diabetes. We'll call him a female. He had a gender change. And he has type 2 diabetes for 12 years. Now we're up to 12 years. His A1C has gone up. This is a guy you probably put on a sulfonylurea. Or maybe you didn't change. You said, oh, well, you know, he didn't want to pay an extra copay. Now, 12 years, he's on glargine, 90 units HS, and aspart, remember that's going to be Lantus and Novolog, 30 TID. That's a whale of a lot of insulin, plus his metformin, his fasting glucose. Oh, look at that. 85 to 180. And what's his PM glucose? Oh, heck. It's the same as it was, 3 years ago, basically. So we're not any further than we were 3 years ago, and he has now gained 40 pounds. So his food plan is still very reasonable. He checks his glucose twice a day, and the problem is still where it was, and the A1C goal is still about 7.5. But now he's really up there, and his complication rate, particularly his cardiovascular complication rate, is going to go up exponentially. So what are we going to do about him? We now really must use the GLP-1 agonist, and you're going to be able to decrease that aspart. You may be able to get rid of it. And if there's one thing my patients want to do when they have type 2 diabetes and they're on 4 shots a day, is to go down to 2. So again, and you now can do that. The insurance company is going to be just blissfully happy because you're going to reduce the insulin. And for some reason, they like to do that. You're also going to reduce the weight. So think about the GLP-1 agonist. It is a very good tool to get weight down. It's a good tool as a next-line drug, and it's a good tool to reduce the rapid-acting insulin, which is causing this person to gain weight. Yes?
Splitting the glargine help?
Well, splitting the glargine. No. You can split the glargine. I do it in patients who are taking more than, actually you could, because he's taking more than 50 units. And how many of you used a pen? Actually yourself, right. Hard to push that in as you get to about 60 units. Glargine has a back pressure as it precipitates to the injection site. And so you get bruises and you get irritated areas, and you get a big lump. If you have somebody that has sub-Q tissue, you can just feel in there and get a big lump of glargine. So it would help in terms of just simple ease of administration. And if they don't hold the pin in long enough, it runs out if you put in more than about 50 units. So you can help him there, but in terms of making his control better, probably not. Once you're in a steady state, after 2 or 3 days, your glargine level is just flat. You know, it really is a 24-hour insulin. If I have people with renal insufficiency, sometimes I give a bigger dose in the morning because 15% of the time glargine peaks a little bit. And it prevents them from having nocturnal hypoglycemia. But in general, I don't necessarily. But again, 90 units, you're right. We could at least split that dose to, say, 50 and 40. Okay, so remember the GLP-1 agonist. How about the DPP-4 inhibitors? Well, again, we have a collection of those. And they're very helpful in patients with renal insufficiency. They may be used in conjunction with a long-acting insulin. Remember, people who have renal insufficiency don't have big meal excursions. In general, they don't have very high glucose after meals. This works very nicely for them. It can be used outside of renal insufficiency, of course, and they're weight neutral. So let's take a look at this one. 77-year-old male with type 2 diabetes for 15 years. This man has autonomic neuropathy. He has stage 4 renal disease. His BMI is 26. He's had an MI and a CVA, and he takes Dedamer, that's Levemir, 8 units in the morning. Again, renal insufficiency, give that long-acting insulin in the morning in case it has a little peak. His A1C is 8.4. What is his A1C goal? This is controversial. You talk to the nephrologist. My friend the nephrologist keeps telling people, you need an A1C of less than 7. And I said, over their dead body, because we give them hypoglycemia after a CVA and a stroke and a heart attack, and he's going to be dead. If you have diabetes and you've had one heart attack, chances are in the next 5 years you'll have another, and your chance of surviving that is less than 20%. So I'm going to be very careful with this gentleman. What's his A1C goal? Less than 8? The curve becomes exponential in terms of complications as you get to 8 and 9. So most of us say less than 8 for those very fragile patients. Okay, now his AM glucose is 76 to 96. Wow, that Dedamer's really working. And I worry that in the middle of the night, his glucose is 50 or 60. So I have all these people rise up, as we say in Texas, in the middle of the night and check about a 2 a.m. glucose. I want to know that's in the 70s and 80s. And if it is not, we're going to lower his Dedamer. We're not going to, I'd rather see that A1C, the glucose in the morning ride up a little bit. We don't want nocturnal hypoglycemia. He's not going to wake up, and that's the time people have heart attacks and strokes in the early morning. So we're going to say his goal is less than 8, and where's the problem? The problem is post-meal. It's obviously not in the morning. So his problem is going to be post-meal, and these 140 to 210, sometimes, as a matter of fact, the majority of the time people like this, is because they're going someplace, eating out. They're usually dietary problems here. But this is the ideal candidate for a DPP-4 inhibitor because it will take care of this meal excursion and rarely, if ever, causes hypoglycemia, even in patients with renal insufficiency. So this is a good niche for that.
Do you have a favorite when the GFR is 27? Do you believe in the idea?
Do I have a favorite? They are all pretty much the same, and you have to reduce the dose of most of them when you have renal insufficiency, except linagliptin, which put it out there so you wouldn't have to reduce the dose, because they don't think I know how to cut things in half. But I do. So I use the one the insurance company favors. And with all these, I might say that it is more work to discuss with the insurance company that you have a particular favorite than it is to just use their favorite and alter the dose. And that goes for most of these things. Okay, so remember that the FDA is reviewing all the GLP-1 receptor agonists and all the DPP-4 inhibitors. They're reviewing all of the data. And they're saying that we must discuss pancreatitis with these people. We need to tell them about pancreatitis, just your little spiel about how if you have a bad abdominal pain, nausea, vomiting, you stop this drug and you give me a ring. And it only takes you just a few minutes. They also say you have to discuss neuroendocrine tumors, which takes me 3/4 of an hour with the fellows. So you're not going to do a big discussion of that. You're going to say rarely, incredibly rarely, mainly in animal data, there have been some unusual tumors. So we're going to just talk to you when you come in yearly. We're going to think about this. But neuroendocrine tumors are so rare, it's not worth the collective effort. And the FDA has now said that saxagliptin is not associated with congestive heart failure. There was a worry about that last year, so if you're worried about it, this should set your mind at ease. Okay, let's talk about the SGLT2 inhibitors. But if you have questions, don't hesitate to stop me because we're whizzing along here to kind of catch up. SGLT2 inhibitors, remember that you eat glucose. It's all deposited into the renal filtrate, and then you retrieve what you need back. You retrieve more than what you need back using the SGLT2 transport system. It takes the glucose out of the filtrate and thus out of the urine and back into your bloodstream, so you won't get hypoglycemic. And we have two sets of these in SGLT1 and SGLT2. The SGLT2 retrieves the vast majority of the glucose. So if we could inhibit that in people with diabetes, all that glucose would go into the urine. Actually, it's about a 50% inhibition. And the glucose in the bloodstream would be lower, right? You'd lose calories. Wow. And you'd also decrease your sodium by increasing your sodium loss in the urine. So it decreases blood pressure. Rarely do these cause hypoglycemia because the SGLT1 system hauls back some glucose if the glucose in the bloodstream is getting low. Do these work? You bet. But what are the adverse effects? Well, as we just said, you have a high urine glucose. So if you have increased urinary tract infections in these people, increased fungal infections, increased vaginitis, and I know this is a women's conference, but you know who gets the most into trouble? The uncircumcised male. I've had, incredibly much more balanitis than I have vaginitis. And you'd think that the obese lady with the type 2 diabetes would have more vaginitis, but don't see that as often. Osmotic diuresis. And so you have to be very careful in these people. They can get very dehydrated, and when they get dehydrated, they can get ketoacidosis. Remember, the ketoacidosis depends on two things: and a relative absence of insulin, which they have, and an absence of carbohydrate, which if you had them on a low-carb diet they have, plus dehydration. And if they become dehydrated, they're going to get ketoacidosis. So the FDA has just put out a bulletin on that. You need to be careful of it. So my thought about that for all these patients is drink a lot of water. In Texas, that's at least 1.5 liters a day in the summer. I had an oil rig guy who forgot his water, came into the ER with ketoacidosis on one of these things. So they're very safe as long as you drink plenty, plenty, plenty of fluid. Okay, there's some combinations of these. Yes? Type 2, type 2. Remember, the type 2 can get DKA if you kind of push them over the edge. And he did. He was dehydrated. His creatinine was 3. He hadn't had any water all day. And these are relentless. I mean, they are relentless osmotic diuretics. So that they don't stop because you're dehydrated. They can make you into a prune. So you have to be careful with them. They are not as benign as we used to think. Where are you going to use them? somebody who needs an A1C of less than 7, this is a 45-year-old gentleman with type 2 diabetes for 3 years. He needs an A1C of less than 7. He has no complications. A1C is 8. We can use something like an SGLT2 inhibitor along with metformin. He's still on an oral agent. Now, I want to tell you about, we're about at the end of our rope here, but I do want to tell you about the new insulin. You all know about these old ones. We've been talking about them for years. We have the rapid-actings that are designed to cover carbohydrate before meals. We have the long-actings like Detamir and Glargine. And we now have inhaled insulin. And we also have Glargine U300. I ought to mention that. It lasts for 36 hours, and it is just 3 times as concentrated. It's not a new molecule. It's just 3 times as concentrated. So, you know, you have U100 and U500 regular, and now you have U100 and U300 Glargine. So you just have more units in the pen, basically. And so think about that. But the really exciting one is inhaled powdered insulin. And it's called Afrezza. And this is the delivery device, which is really easy. I mean, almost anyone can use this without any instruction. It comes in metered units so that you deposit either a 4 or 8 unit blister pack in, you press the top, you take a breath, and it's on board. And believe me, it peaks in 12 to 15 minutes. We were part of the study that had this approved for the FDA, and believe me, it goes. Your patient does not want to take this and then go to the restaurant. You have to take it just before you eat. Okay? It's approved for type 1 and type 2. It's ultra-rapid acting with instant absorption in the lungs. You say, wow, this sounds great for people who don't want to take extra shots. But you have to remember that you have to look for lung disease. If you use this in patients who have abnormal spirometry, in patients with COPD or asthma, can lead to acute bronchospasm. You have to have normal spirometry in the beginning. You check again in 6 months. If it's abnormal, then you have to take them off. It is a lung irritant without a doubt. We don't know if it's going to cause cancer down the line, although the FDA just looked through all of our records. We did this study a long time ago, and they looked at all the long-term follow-up. And they said so far no one has had an increase in lung cancer. But again, it's a lung irritant, so we have to mull that over. I won't even let Dr. Pell, who's a pulmonologist, talk about that. You talk about it in your own time, Don. Okay. So you can get hypoglycemia. It can be severe. So you have to eat after you take this. It's a pre-meal bolus, and you must eat. You must eat within really about 15 minutes. Okay, this is the lady you want to use it in. She is the poster child. She doesn't want to take extra shots. She won't take this. She won't take that. She doesn't want to check her sugars. This is ideal for her. She inhales it before she eats and goes on with her day. She will check her sugars, but not at first. So, and I think probably, should we stop here because we're right at the end here. So I think I'll probably stop here. And we will go on to Dr. Basil because I don't want to take up his time here. Okay, so I want to get back on time here. If you have questions about type 1 diabetes, be happy to answer.